Okay, this is, again, we always try to design these things a little bit for two audiences, surgeons who are interested in getting their practice into our kind of procedures, and uninterested patients who want to do a little bit more qualified research. And what this is about is what most patients will call hip dips. Surgeons like to call it trochanteric depressions. And in the end of the day, I can say, look, my whole clinical career is dedicated to fighting the hip dip. And yeah, unfortunately, it is a little bit of a hard opponent, I have to say. But this is to give you a guideline how to handle that, because unfortunately we can't just erase what we don't like and draw something new. Some patients tend to think so, or even surgeons. It's a bit more complicated than that, but there are very, very effective protocols how to deal with that. So, surgeon terminology, trochanteric depression, and many call it the Mendieta C point. Dr. Mendieta was one of the first ones to describe that, a surgeon from Miami, and he called it C point, and I can kind of stayed with that. What is the problem in this area? You have, the skin is going in a little bit. You have often very tight skin, especially in body feminization, male to female gender reassignment. The blood supply is not great, to say at the very least. So it's a bit challenging for the little fat grafts, all these cells to take. I always compare that, let's say, to a pond with a low oxygen content, and then you put trouts into that pond. Trouts need a lot of oxygen, like your fat cells need oxygen. And in that area, there's not so much blood for them to feed on. You see this in the little sketch here. The red arrow points at the area that we really want to expand most. And unfortunately, in some patients, it's a bit resistant to expansion. So what we want to do is kind of expand the tissue, loosen the tissue up so kind of receive more fat grafts, but not over-expand. So we destroy the tissue scaffold. And you see this here in one of these famous in-surgery side-by-side shots. The hip dip here is expanded. This is why we call it expansion vibration lipofilling. We get a short insight into how that works. In the second, unfortunately, it doesn't stay like that, because then you have swelling and fat resorption afterwards. But it gives an indication about what we're trying to do in the surgery. And you see, one of my most favorite documentations of a BBL recovery, you see you go from nothing to massive and then to normal. And where you see the red arrows here, this is why I call it the set zone. This is where fat grafts usually is most challenging. Because again, the blood supply there is not optimal, to say the very least. Now your limitations, the tighter the skin, the less you can put, because what you don't want is pressure killing your own fat grafts. And the solution for this is what we call achievable lipofilling, expansion vibration lipofilling. Credit to this, probably be eternally thankful for him for showing me that. It goes to Dr. Dan Delvecchio from New York, who taught me how to do this. I think if I compare that to the old days with the syringes, and I'd probably shoot myself in the head before I would go back to that technique, I would roughly say you can graft 30% more with a better success rate. And the deeper the hip dip, the higher the likelihood that you want to go and graft again. We've chosen an extreme example here. But you see, it's always limited by the graft capacity. So this is important for patients and surgeons to understand. And you see here, we just picked an extremely challenging case where you don't even only have hip dips, but the kind of V shape. And then, this worked out like in 2 sessions, which I think it worked a bit better than we thought. But I like to always maintain also with patients an understanding before what we can achieve is what we get to work with. So in these extreme cases, multiple sessions may have to do the trick, because it depends on what scaffold we get. Now, this is more for the surgical audience. A few, let's say, technical details. EVL lipofilling, we recommend to do this with 5,000 oscillations per minute, a flow rate of 300 milliliters per minute. Careful, this is, I think, once you have a certain experience or tactile feel for how to do this, I wouldn't start with 300 milliliters per minute. if you are a beginner, if you haven't done that many times, I roughly use an expansion to infiltration ratio of about 1 to 1. The learning curve is steep. You don't want to overexpand, and you do not want to overfill either. So if you expand too much, you break the scaffold, and if you expand too little, you have too much pressure. So it's a bit of a tactile skill. It's something which I say you have to feel. You can't just see a video and then go and do it. I mean, you can do that, but I wouldn't recommend you. And because we are really working very hard to get this procedure more widely accepted and more widely practiced, and I feel the huge privilege to call him a friend. That's Dr. Del Vecchio, who is the inventor. He was the first one to do this, and I probably never forget in my life when I saw him do this the first time, which was I think 2012. In the World Aesthetic meeting in Paris, and I think there was a massive audience watching him do it, and nobody understood what he's actually doing because he was so far ahead of his time, and he told me how to do this. So we want to pass that on, and we've got the huge privilege that he's coming to Marbella in normal times. Okay, COVID now has students a bit down. Twice to us, and we offer surgeons the possibility to feel this, to learn this from the guy who's invented that, and we've limited to 8 seats, and I think it's a great thing, to get people out there to do this safely, if you like the bigger events, and we are really hoping for this to be already in the post-COVID area. Let's hope you're invited to join our big congress in June, which we hope to release our program soon, and I think you will be amazed, and we hope to welcome you in Marbella for that.